Hello, everyone. I'm Raul Santos from São Paulo, Brazil. I'm the editor of Global Heart, and I'm very honored to be here on this panel, the Heart Café, where we're going to discuss the hurdles, the barriers, and possible solutions for secondary prevention. This Heart Café is sponsored by Amgen. I really like to thank them for supporting many activities of the World Heart Federation. And I have the pleasure to be with my colleagues here, Professor Clara Shaw from University of Sydney, Australia, Mr. Ram Khandelwal from India, right, from the Heart Health India Foundation, and also Dr. Sarah Fori from McMaster University. And the idea is discussing a little bit their own experience, suggestions on this issue of secondary prevention. We know that someone who's already had a cardiovascular event has a very high risk of recurrence of these events or even dying of cardiovascular disease. Fortunately, we know how to reduce the risk of recurrence. We are aware of the pathophysiology of the disease, and now we have many therapies, not only an adequate lifestyle like stop smoking or exercising or trying to lose weight, but we have many pharmacological therapies, and the good news is that most of them are generic drugs and expensive drugs that can really make the difference and reduce the risk of recurrence of events and death. Certainly, we have now newer therapies that are more robust and can add benefits to the ones that we already have. And sometimes we have the issues of access to these therapies, especially in low and middle income countries. And in some situations, even despite the fact that we have all these available therapies, our patients simply don't take them because lack of understanding of the disease, lack of time, sometimes the prevention programs are not adequate. So definitely we must finding ways of really reducing that. Just one very sad example from Brazil. We made a survey of more than 2 million patients on the primary care in Brazil. 35,000 of them were in secondary prevention or had an MI or stroke. And only 10% of patients who had an MI were taking statins, 10%. And only 7% of the whole secondary prevention patients were taking statins. So this is something that is very serious, and I guess this might also happen in other places of the world, and definitely the idea is really trying to discuss the possibility of improving this care. So I'm going to ask my first question. Let me just find here. And so the idea is asking one question to each one of the panelists, and then we keep rotating among each other, and we have an hour. So my first question is to Clara. So Clara, in your opinion, what are the key health system limitations preventing effective secondary prevention, especially in primary care or in under-resourced settings?
Thank you. So, I mean, obviously, there's a lot of variation across the world, and in many different low-income settings, they'll have different challenges. I suppose one thing that is, though, pretty common and across all of those is access, as you indicated. So access is a multidimensional thing, though. I mean, we simply think about access as access to medications, which is obviously a very important component to access. But even when you look at access to the secondary prevention medicines that are on the essential medicines list, which is actually only a very small proportion of now what's indicated for secondary prevention post-MI, that access can be as low as 20% in some lower middle income settings. I mean, that's talking about access to antiplatelet medicines, cholesterol lowering statins, and blood pressure lowering. And that, as you indicated, it doesn't even think about all of the other medications now that are indicated for secondary prevention. But access is not about just, access is things like cost of it, but it's also about whether it's sitting on the shelf. It's also about whether the medicines are even distributed to the communities and primary care areas. It's also about having access to a doctor to prescribe the medicines. It's also about having a health infrastructure or pharmacy or anything to access it. So I suppose I'm trying to say the word access is not that simple. It's quite complicated. It's easy to roll off the tongue that access is a problem, but it is obviously a multifaceted problem and probably one of our biggest health system issues. To touch on a few others, though, I think I mentioned capacity and health infrastructure and health workers. In a lot of low and middle income settings, there's insufficient healthcare providers to be able to manage patients or support patients after their heart attack. This doesn't necessarily have to be doctors, but I mean it'd be useful to have some of them. But other health workers to be able to support secondary prevention. Many places around the world still have insufficient healthcare workers to be able to support the delivery of secondary prevention. As we know, cardiac rehab and education with respect to smoking and all of these things seem simple, but are a lot more effective if you have a supportive healthcare providers, cardiac rehab services, other services to support those important lifestyle behaviour changes. So I'd say kind of a second broad issue is the capacity around healthcare workers. And maybe I'll tag one other third broad issue, just being a health literacy in a broad term. The understanding of how important secondary prevention is after a heart attack. In some countries, obviously, higher income countries or urban cities, I think it's not only the doctors that understand it, but clearly the patients that understand it and the health system that understand it. So, there's a high level of health literacy that this is an important problem and we have to all attack it together. But I think in lots of low income settings, there's not that combined multidisciplinary high health literacy understanding of the importance of secondary prevention post-MI. So I could probably go on, but I should probably leave it at that.
No, thank you. This is great. Yeah, actually, it's a really very complicated issue, right? So I'm going to ask Ram about the patient perspective, right? Because it's extremely important, because actually patients are those who we serve, and we need to have their opinion, their voice, to really understand from their point of view. So my question to you is, as a patient advocate, what do you think healthcare systems often overlook when trying to support people with established cardiovascular disease?
That's a very interesting question, and when patients, you ask them that what's wrong, why they are not taking secondary prevention seriously. I think patients lack a lot of understanding in terms of the disease itself. The term secondary prevention itself actually comes from medical terminology, right? When I say a patient, I'm talking about secondary prevention, they say, oh, what? Oh, you should not have a second heart attack after the first one. Oh, I get it. So I think we need to be simple in our ways how we communicate. And the education right now, we don't run structured education programs. Just making a leaflet or a booklet and sending it once doesn't serve the purpose. When we started our education, we became literate. We went through years and years of health education to be where we are today as professionals. But when we talk about health education, we don't have structured learning systems. In India, especially, it's complicated. Reason being, we have both public and private sector. We have about 70% of the population load which is going to private sector. So in public sector, we still see that there are educational programs, there are different health literacy materials which are being created. But when we look at those 70% who are going to private sector, they're only going there for treatment. One common misunderstanding which most of the heart attack patients have is that heart attack was the disease. No, it was an event. The disease is something which you live with for whole life. And being a silent killer, being asymptomatic, in the first place you never knew that it was happening. And today, when you start feeling symptoms, because you have no symptoms, right? You have come out of a hospital, you have gone through a cabbage or maybe a PCI, now you are feeling okay after a few months, you are feeling normal. And people think that, like, I've left the medicines for cough and cold, I can leave the medicines for heart attacks, which is not true, because people just say that you should not leave it, but they don't understand that patients need to know the why behind it. Until unless they internalize this fact, this is a coronary artery disease which they are living with for a lifetime, they won't be able to tackle it. So our education protocols need to be designed in such a way, like we have done classroom education. These patient support communities, these patient support groups acts like an atmosphere where can actually people learn on an ongoing basis. So I think education and literacy are the fundamental problem that we need to solve, because no patient wants to die. Believe me, no one. None of their family members want it. And they are trying everything to live long. It's just that they don't understand what they are dealing with. The moment they know it, they'll be better equipped to deal with it.
Thank you. Thank you so much. Now for Sandra, what do you think is the single biggest gap keeping secondary prevention from working in real life? And where should we focus first? That's not simple.
That's a really loaded question, because it's very contextual. It depends on the health system. It depends on, if we're talking about high, middle, or low-income countries. It'll be different across different health systems. But I think one of the key things is not that we know what to do, we're just not doing it well enough. And from yesterday and today, we've talked about a lot of the factors. Clara and Ram have already mentioned some of them. But I would say, at least, well, in high-income countries, I think one of the key things is the continuity of care. So patients are seen in hospitals for their acute event, and they're discharged home. And we assume that they will see their family doctors in 1 or 2 weeks. And that's an assumption that doesn't really bear out, because family doctors are overloaded with other things. And if we don't have any direct system where these patients are fed back into primary care with support from the specialist to the primary care provider for the patients, then we really run the risk of there being gaps in their care. So a practical example will be patients who you see and discharge home, and they don't fill their prescriptions because you give them a prescription at discharge and there's no guarantee that it's filled. Nobody has seen them for 4 weeks. I mean, there's many studies that we already know that when adherence to GDMT obviously lowers mortality, and many observational studies have shown that adherence to GDMT falls by at least 30% in the first 30 days. And this just reveals gaps in that continuity of care between specialist hospitals and primary care providers. In low-income countries, I would say it's more health system problems. So education is a key part of it: physician education, healthcare provider education, as well as knowing and informing patients using universal language so that patients are not getting different messages from different healthcare providers. If we're all speaking the same language and educating patients in the same way, then at least we're going to be providing them with some knowledge. But beyond that, in places where access to care and access to medications is a big problem in low middle income countries, it has to be health system level implementation. So for instance, we can learn from infectious diseases, from HIV care, for instance. It's a bundle of care, it's a chronic disease care model in which patients are seen, they're educated, they're provided medication. Imagine a scenario where patients get discharged after their MI with 3 months of medications at least. I mean, that would be sort of like, it takes it away from the patient and more on us and the healthcare system to provide that initial, gap before they get set up with their primary care providers with cardiac rehab, without us running the risk that they lose, that initial benefit that they get from initial adherence to GDMT. So in summary, we have GDMT, we know it works, we're just not getting patients, on them as well as we should because of gaps in continuity of care.
I think it's really complicated because you don't have cardiovascular disease specialists to take care of everyone, right? And sometimes the primary care physicians, they're not aware exactly what they should do, as you said, and they have any other diseases that they have to care at the same time. So I think it's a real gap, and has been previous said here, we do need this thing about the education and literacy in different levels in order to not only the patient, because the patient needs to know that he or she will have to take those medications for the rest of their lives, because they really can save their lives, but also the primary care physicians not to suspend the therapies. Of course, patients having an adverse events, side effects, etc., but and it happens a lot, especially, for instance, reducing the dose of the statins, things like this, you know. And definitely this is something that we must discuss and increase the knowledge about the need for keeping this. So, okay, so I have now another question for Clara regarding what approaches have worked to improve patient adherence, not just as the point of care, but months or years after a cardiac event. So this is...
You smile because it's not easy, huh? I think that, I suppose the problem is that taking a lifelong preventative medicine is not easy, and I think we know the data that immediately after a heart attack, to the months and years later, there's a clear decline in the use or adherence to secondary prevention medicines over time. In terms of how to address this, there are a number of intervention studies, but a few simple flags first. I mean, we know that if they're prescribed all of those medicines in hospital immediately after the heart attack, that's one of the clearest markers that they're going to be on the right secondary prevention medicines, longer. So if they're not prescribed those medicines at that time point, they're less likely to use or be adherent to those medicines. And maybe that speaks about that gap to primary care as well, that it is important to get them started well right away. In terms of specific things looking at medical adherence, I think a lot of us know about the combination pills, poly pills, fixed dose combinations, all sorts of different terminology. But it is easier, I think, for patients to take a fewer medicines. And so if all the secondary prevention medicines are combined into a single medicine, there are a number of trials now that show that enables or gives better adherence to secondary prevention than if they're on multiple separate pills discreetly. In terms of other kind of factors, patient education, there's a number of patient educational interventions that show that improves adherence or continued use. Of course, there's all the barriers to address as well, and I sometimes think it's unfair that we call it adherence or to medicines when people have become non-adherent because they cannot afford the medicine or it's no longer available, but we often call that non-adherence as well, and it's not a barrier that a patient can deal with necessarily. Things like cost and affordability. I mean, I think that, if you had the option of paying for your kids' education or whatever, food for the house or your medications, I know that is not an easy decision for some families. And I think that these factors aren't easy for a patient to deal with or to address directly. But I want to flag that because if we can deal with cost, that would be an important thing for adherence. Maybe the last thing I'll mention is there are a number of things like reminder systems and other things, electronic reminder systems. Maybe we'll talk about some of these things later, but that can also improve adherence.
Thank you. I think the issue of not being able to, let's say, buy the medications is really a big one still in low middle income countries, but also the lack of knowledge about the benefits that these therapies can bring. And in my area specifically, statins, right? And nowadays with the fake news, the misinformation, it's truly a hurdle. And even knowing that these drugs can really save lives, patients may stop these drugs because I might get diabetes. Okay, you might get diabetes, but it's not exactly the statins that are going to cause that, right? And all the bad things that are said about, and definitely the question of literacy, education, information, and I keep wondering, because usually if there's only the physician who has to see the patient, it's trouble because you have small amount of time and you don't have time to talk with the patient about the needs to take these drugs for probably the rest of their lives, the benefits, the possible adverse events. So I think it's extremely important to have the multidisciplinary team to work together and to really build on this, because only one person is not going to, can help, but I don't think that will be enough so to really trespass these barriers. And we discussed that a lot when we published the cholesterol roadmap about not only the access, but really this issue of really making the patient take the drug for a long time, and also the monitoring about whether the drug is working or not, because you might need to add other drugs. It's like blood pressure, right? Lipids is exactly the same, because you have to check whether the drugs are working enough for that person. And if you do not monitor the patients, and this is a really big issue. So coming back a little bit to patient perspectives and to run again, what did you think would have made the difference for you or others in your community in terms of follow-up care or support after a heart event? Something that really think can really help.
So I would say I think it's a marathon. It's not a sprint, and it starts right after you come out of hospital. A lot of times when patients are discharged from hospitals, they don't have a roadmap. The only thing that they have is a discharge summary and a prescription, and that's their roadmap. But they don't know how to interpret it and what it looks like to have implemented in real life. I think some of the things which I felt, so I had a heart attack at 33, and I was left stranded. I and my wife, it took us 3 months to came to this realization that we are living with a chronic disease, and life is not same anymore. And it's not just my story. Someone texted me on LinkedIn yesterday and then reached out to me on WhatsApp. Ram, my husband had a heart attack at 35. I'm looking to talk to someone who has walked a similar path. Can you connect me with someone? Because the issues that patients face, they have no clue. Nobody plans to have a chronic disease in their 20s or 30s. And the moment it happens, it just sets you off. So I would say maybe if we take one step at a time, maybe when the patient is in hospital, start explaining them why this happened. Every patient asks that question, but it took me 5 years to find that answer. I've met so many HCPs, I've taken so many tests and answered so many questionnaires to understand what caused my heart attack. Because unless you understand what is the root cause behind it, you will never be able to handle it. If medication is the way to go, the reason you should know why we are doing this. And when patients start understanding, that makes a lot of difference. And small steps, maybe having a small kit for patients during discharge, which has booklets on different education aspects. When they are moving out, giving them counseling on nutrition, medication, exercise, enrolling them into cardiac rehab. Especially the country where I come from, we don't really pay a lot of attention to cardiac rehab. We don't make referrals for cardiac rehab. And I myself, I learned about cardiac rehab when I went back home and we start searching that how do we live long? Okay, cardiac rehab could be one way of improving our chances. We went to a doctor and asked, okay, prescribe me a cardiac rehab. But this should not be one-off case where a patient is going and asking. This should be part of healthcare system. And these are the things which we can actually make and integrate them as part of standard of care. So unless we make them part of standard of care, it won't happen. Medication adherence, big out-of-pocket expenses. Especially the country where I come from, post 90 days, you don't have coverage for medications. And you are given a load which you have to carry for life. And if you don't realize the importance of same, you would often think, okay, I'll just cut it. Maybe it will save some money. Why I'm wasting it? I have no symptoms. So there are multi-pronged approaches we need to look at from policy making side, from hospital administration side, from clinical journey, patient care pathways, and from behavioral change aspect side. Patients adhere better when they have a behavior change. And behavior change doesn't just happen overnight, it happens over time. And that behavior change is triggered by dialogues, by communications, by patients talking to each other. If we always keep on seeing our cardiologists who treated us in the position of authority, we hesitate to ask questions. And if we don't ask questions, we will never get answers. So that empathy has to be brought into the system. That empathy has to be brought into the standard of care. And I understand that HCPs have very limited time, and I think in some moments saving lives is much more important than counseling. But then we need to bring patient counselors in hospitals. We are not using that mechanism. Let patient advocates become the patient counselors. There are mechanisms available. I think we need to do a bit more exploration that how it can work.
I think what you're saying is extremely important because communication and empathy are things that healthcare practitioners must have when dealing with patients because we're dealing with people, we're not dealing with machines, right? And what happens is that, as you said very well, most of people who got the disease, are unaware of what caused the disease, are unaware that the disease may come back because coronary heart disease, atherosclerosis is a chronic disease, right? Or heart failure or whatever you have of cardiovascular, it's there, right? And it's chronic, it's not gonna be healed, it can be controlled, and it may come back. The clinical manifestations may come back. And definitely we must find time or have someone else who can do this and communicate and clarify and educate and really try to help, because otherwise we prescribe the drugs, the patients stop taking them because sometimes they feel, oh, I'm very well now, I'm gonna restart smoking because I'm feeling okay. Sometimes this happens, right? So I think this is extremely important. So I have another question for Sandra. What policy or pathway changes best anchor long-term secondary prevention in primary care rather than episodic specialist visits?
Yeah, I think that's a really important point because realistically, we can't anchor secondary care in specialist offices. It has to be in primary care. But then that cannot just happen because we wish it to. It cannot happen in a vacuum. It has to happen with real policy changes and implementation. And one of the ways I think that we can sort of more anchor secondary prevention in primary care is to provide direct support to primary care providers. Now, let's not forget that in many parts of the world, especially in low middle income countries, primary care doctors are doctors who have finished medical school and maybe 1 year of internship training, and they're independent practitioners with no sort of further advanced training. So when you have a patient who's post ACS, discharging that patient with very clear discharge summary, very clear instructions, very clear targets will help the primary care provider in even actually, continuing what you're doing. You gave an example of, people reducing statin doses because LDL is now at target. That's a very common thing that happens, and that's a gap that can be breached by clear communication between specialists and primary care providers in terms of why we're doing what we're doing, why we want to continue these medications long term beyond just the numbers. And I think this is where we also have the opportunity to leverage on virtual care and digital health technologies to support primary care providers in providing that kind of care to patients. So where primary care providers have access to a specialist through some kind of virtual care mechanism, that can help them when they're seeing those difficult patients or those secondary prevention patients in order to make sure that they're meeting the targets that they're supposed to meet. So, we have this system in other disease conditions where primary care providers have specialist support to see patients and only, end up referring when it's beyond their capacity. So if we're able to embed that kind of sort of digital support in primary care, then we can offload some of the burden, from them, because we're giving them the load, but like we have to also be able to support them in delivering that care. That's one thing. The other thing is it needs to become a standard sort of quality assessment. Because if you think about it, many primary care providers are already very good at other healthcare preventive mechanisms. So mammograms, they know, your family doctor will call you when it's time to schedule your mammogram or schedule your pap smear. But we don't, when they're not calling their secondary prevention patients to make sure that they are on target with their lipids, their glucose, and all these things. So until those things kind of become like quality indicators, where family care providers have to make sure that they meet those targets for their patients who are secondary prevention patients or ASCVD patients, then that kind of more embeds it as a cultural tradition. And I think that's what we start to see some small increments in at least those performance measures. The other thing I was going to mention, especially with what you said, Ram, with patients and patients understanding why they've had the condition they've had, and why they need to stay on the medications, why they need to implement the lifestyle changes. Especially, again, I keep coming back to low middle income countries because I'm from Nigeria and this is where I practiced most of my life before moving to Canada. Medication access, medication costs is a big deal. You said in India you have 90 days of coverage. In Nigeria, we don't even have 90 days of coverage. So patients leave the hospital and everything is out of pocket from day one. So of course you can imagine how much patients decide what to buy and what not to buy. There's so many patients who will buy the aspirin and not buy the clopidogrel because it's just too much. So cost is a big issue. So if in primary care we can also make sure that providers are providing education to patients about the importance of lifestyle medication in addition to the meds, because many times it's easier to just deal with the meds and go off because they are overworked. We don't have counselors in clinics. We don't have social workers embedded in primary care. So if we really want to take this care into primary care systems, we need to really support them by making it policies where we have educators, counselors within the primary care setting that can provide rehab, education on lifestyle modification while the family care doctors are dealing with the medication aspect of it with support from specialist care, if that makes sense.
Definitely, I think these interactions, especially telemedicine, telehealth, can help a lot the primary care physicians. We have an interesting experience in Brazil where my hospital it's a university hospital, tertiary care, and they have interaction with primary care doctors in some diseases and to help them discuss the more complicated cases and give them support. And I think this is extremely, extremely important. And also what you said about the quality assessment, because you have goals for blood pressure, for lipids, for glucose, for exercise, whatever. And definitely if you have a checklist to really say, okay, the LDL is okay, but blood pressure is too high, the glucose is not okay. So I think this can because if we have let's say like a protocol. Okay, we're not machines, right? But these protocols, they can help us a lot. Because when I don't understand about a given disease, I check the information about that disease and say, okay, it's like this, right? So I think to having reliable and easy ways of assessing these protocols and the recommendations, I think this is extremely, extremely important. In talking a little bit about these digital tools, right? I think for Clara, so how can digital tools like remote monitoring, SMS reminders, digital prescriptions can help improve adherence and continuity of care in secondary prevention? And in your point of view, what would be the limitations or risks of relying on these digital strategies, particularly for older patients and for those who in low connective settings? So. Yeah.
Thanks. I mean, I might start by saying, gosh, it's now 10 years since we published a trial called Text Me, Tobacco, Exercise and Diet Messages. And this was a post-heart attack trial. And what we were responding to, actually, what Ram said, that concept of patients not understanding a roadmap of what was going on after a heart attack, and the period of hospital time being so short that, you know, we dump all this education on these patients and then hope that they'll sort themselves out for the rest of their lives with their new diagnosis of coronary disease. So TextMe was a text message-based intervention where we gave them bite-sized chunks of education about their lifestyle risk factors, their medications, basically an education about heart attack across 6 months after their heart attack. And the intervention participants achieved lower cholesterol, lower blood pressure, were more likely to quit smoking, and more likely to modify their lifestyle behaviours. Now, since that time, there have been a number of digital health studies that have looked at this in different patient populations, in slightly different health conditions, with a similar kind of a finding in general that these interventions, digital interventions, these reminder interventions, these sort of bite-sized chunks of information across a period of time delivered digitally help with things like being adherent to therapies, help with things like understanding of their treatments, and help with modifying behaviours. So, I mean, I'm proud to say that now in our hospital, after discharge, patients are sent a text message whereby they can enrol into a text message-based program. And, you know, over the last few years, we've had now over 10,000 patients receiving the text message-based program, and it's an easy thing that we're able to run post-discharge. Now, you also asked around, I suppose, the limitations and barriers, though, in these digital interventions. I have to say, 10 years ago and even now, I mean, I think we're all amazed at how the world is just so much more connected with mobile health-based interventions. And we did start as a mobile health-based intervention. So in some ways, I think the technology barriers themselves, at least to simple mobile health style interventions, are much lower than they have been, and I think they're increasingly being, you know, dealt with. In terms of limitations for older versus younger versus different literacies, I think that a barrier to them is the complexity of the interventions, and I think a number of things about that. One is, you know, the more complex apps and more complex interventions where they require a lot more monitoring and things are challenging, and increasingly thinking how the user can interact with those sort of things are important. But I think that the text message-based ones are still pretty easy for people of all ages, sexes, literacies, etc., to be able to deal with. In terms of some of the barriers, I suppose, to or how we can improve some of these things, patients indicate that they want more personalised information. They want it more directed to themselves. They so that is a little bit of a barrier, but you know, technology is changing such that we can be more conversational with patients. We can understand them better. We can personalise them according to their risk factors, and that's a nice jump in technology. It doesn't impact necessarily the patient interface. It's the complexity of the algorithms behind these things that are increasingly being able to be more complex and therefore personalise those interventions. I think that the other thing that are being explored, but I don't think is as clear, is the use of other wearable information in terms of monitoring people post heart attack. And I say there's uncertainty because I don't think there's as clear evidence that having that additional wearable or monitoring data will increment the benefits of these digital interventions a whole lot more. I mean, I'm not saying there isn't, but evidence, and I'm not saying that there's not that being looked at, but that could be seen still as a barrier for low-income settings, because I think we all know some of these wearables are pretty expensive. And so I suppose what I'm saying is I don't think they've got quite clearly proven benefits, so it's we're not yet missing out on things there. Anyway, that's the start of the discussion.
No, thank you. No, it's really a lot, right? So I have a question to Ram again. So because now we do stuff and sometimes we don't ask our final customer, right? what they think about the stuff that we give to them, right? This is not only in care, but also clinical trials. And definitely, we must have the voice of the patients in things that we do. Because you can commit something that is totally, we believe it's wonderful, but if the person that's going to receive it that doesn't understand it, doesn't like it, it's not going to work, right? So definitely we must work together, I think, as a team. And nowadays there's no longer that thing that the doctors are gods and the patients have to follow whatever the doctors tell. It's not like that anymore, right? So, and as well said, the need for empathy, for collaboration, it's extremely important to really make things work. So my question to you is, how can patients be better included in the design of secondary prevention programs from policy to clinical level implementation? Not easy to answer, right? I don't know who made this question.
I think it was Lana for so many years on this. But to start with, I think very important thing, patient organizations as the stakeholders. Yeah. Unless we make in our healthcare systems patient organizations as one of the stakeholders, I think we've been doing a lot of work in this direction and a lot of global work as well as national level. But we need to bring this policy to implementation. The intent is there, right? We always talk about it in forums that patient organization should be part of it. But if you do a retrospective analysis and check how many patient organizations are actually part of such policy frameworks which we have proposed in the policy. So every advisory board, every policy committee that we are formulating, we need to have patient organizations. Sometimes we confuse a difference between a patient organization and an individual patient. Individual patient symptoms will be limited and his or her context will be limited. But when we talk about patient organization, they are collective voice of patients. So they represent rich, poor, people in rural areas, people in urban areas. So the voices that come out of patient organizations is representative and a collective voice of patients. So whenever we are talking about representation, we need to bring patient organizations on board to do it. Once we do it, we actually start talking about continuity of care. We actually start talking about medication adherence. We actually start talking about cardiac rehab. And all these experiences are common and collective experiences, like crowdsourcing patient insights, which might not be possible if only one patient voice is being included in some of these boards, and sometimes they can be misrepresented as well. We pick up an example which may not be representative of all the patients. So I think that's where I would start at policy level. And my second recommendation would be at a healthcare system level. When we are talking about hospitals which are providing treatment, within hospital boards, we need to have advisory boards where patients are being part of system design and system review, so that whatever processes are being followed, because processes are not something which is casted in stone. It has to evolve. Everything has to evolve over a period of time so that we have that delta where we have an incremental improvement as we move forward. So these patient advisory boards have to be part of our hospital ecosystem. And third thing, when it comes to clinicians, I think patient support groups is something which has to be integral part of our standard of care. No patient should be discharged without actually letting them know that they are patient support groups, because that's where secondary prevention starts. The moment somebody becomes parts of a patient support groups, their journey of secondary prevention starts. Otherwise, they leave with limited information and they fall into the same trap in which they had the first heart attack in itself. So I think those are the three main recommendations I would say should be taken up at different levels.
That's great. So thank you. So there's another question for Sandra here. So how should secondary prevention be framed within national cardiovascular strategies so it's treated as a core care and not as an optional add-on?
Yeah, These are very easy questions.
Yeah, but definitely we have to do it because this can make a lot of difference. Cannot be an option. It has to be set, right?
Yeah, exactly. I completely agree with that. But I think where it starts, again, it depends on the health system, right? So in low middle income countries, I think one of the key ways that we can make that we can frame this within our national strategies is, first of all, you can't deal with what you can't measure. So having accurate data in terms of even just the burden of CVD, accurate data, not estimations, because right now most of our data is estimates. Just accurately measuring what the burden of CVD is, I think that tells a story that governments cannot ignore. And we can even start with like just national registries of actual patients who we've seen. So having national registries would be one way to at least measure, and then you can use that as a point of advocacy to the governments and to the policymakers. We have guidelines. We have beautiful roadmaps. The WHF has a beautiful secondary prevention roadmaps. Are the national cardiac societies adopting the roadmaps and implementing, or at least trying to implement them within their healthcare systems? Those are like starting points that we can do. And for it to be core strategy as opposed to add-on, the governments actually have to pay for it, right? So we're talking about primary care. If they can even start to fund provision of support workers within primary care to provide cardiovascular therapies and intervention strategies, that kind of just embeds it into our healthcare system. So measuring, implementing what we already know works within national frameworks, adapting to the local needs, and actually advocating for governments to put the money where it's needed in primary care. And I think also, I don't know, I mentioned this yesterday during the session, I think terminology really matters. Even when we talk about primary and secondary prevention, what do we mean? How are we dichotomizing who's the primary preventive patient versus secondary prevention patient? So in terms of making this sort of core as opposed to optional is understanding that cardiovascular disease is a continuum. Just because you haven't had a heart attack doesn't mean you don't need the same strategies. So recognizing that, and that being sort of how we look at CVD, I think is one way to sort of make it more entrenched, if that's the word to use, within our healthcare system versus trying to dichotomize primary prevention strategies versus secondary prevention strategies, what you pay for, what you don't pay for. Those are, like, I think, ways that we can try to start to make this sort of part of our national, the same way we treat other chronic conditions, as opposed to right now where it's really just left to individual hospitals and doctors to deal with.
The subject of our seminar here is about secondary, but as you said very well, there are people who didn't have heart attacks yet, but run a very high risk of having a heart attack or dying, right? So risk stratification is extremely important because these people must be treated exactly as someone who already had an MI.
Yeah.
So definitely this is something that we must think about and we must change. So I think that the guidelines are evolving on this thing about risk, and basically what you treat is risk, not necessarily if MIs or consequences of it. But this is really, really important. And to understand what's going on, to really try to implement the best strategies, I think it's extremely important. So we're almost done here. We still have a few minutes, and I have the same question for the three of you. And so I think I'll ask you what you would think would be the one priority action for improving secondary prevention globally, and what would it be? So I'll start with Clara, then Ram, and then Sandra.
I find this a hard question, to be honest, but I'll put my comment to say that I think the problem of access to secondary prevention needs to be asked at the highest level of governments around the world, and what are the three things that they're doing to address access to secondary prevention post-MI, because I think that it should be at that level of priority, and I don't think that necessarily just ground level interventions can tackle the challenge of access. And I'm hoping that the consideration of system level changes where we start thinking about how do we make these drugs cheaper, or how do we have localized production, or how do we fix distribution chains, or how do we get these medicines to the different places that actually the patients are. It's not just the role of a doctor and a patient to deal with these things, yet I think that is for many of our lower middle income settings where the majority of burden is the issue that is not being tackled.
Thank you. Ram, what would be your message or priority?
So, saying one is difficult. I think all the points which Clara mentioned and Sandra mentioned, digital to digital health, I also use some of those for my own use. And regarding primary prevention, all those are very, very important point. But for this discussion, I'll stick to a very foundational element, which is patient communities. For me, patient communities is equal to secondary prevention. If we are able to build strong communities, secondary prevention will happen automatically because that becomes the channel to do it.
Okay, thank you. And Sandra?
Yeah. If I had a magic wand, or if I was the president or something, I think two things are a priority. At the patient level, providing access to medications. Because we can speak all we want, but if patients cannot get the medications that we know, we're so lucky in cardiovascular disease. I don't think there's any other specialty where we have so much empirical evidence for things that actually work and reduce mortality. And yet, patients are not able to access those medications in many parts of the world. So if, the core thing will be how do we get medicines to the patients that need them, especially in low middle income countries. So that's number one priority. Number two priority is also when we talk about lifestyle interventions, that goes beyond the level of the patients. That has to be national level, that has to be city level, that has to be urban planning. I think one of a WHF publication last year published cities, the City Heartbeat Index, and Madrid is actually number 3 on that list. And this is my first time in Madrid, and being in Madrid, I can understand why. Everywhere is walkable. There are parks everywhere. There's a park I found this morning, beautiful park. There's a running track, there's exercising equipment. I saw lots of old people exercising. I mean, that's something like, if imagine the patients in this city had a heart attack and you're telling them you have to exercise, you have to do these things, and there's that kind of publicly available free park to go do these things. I mean, those are things that are beyond the level of the patients. Is the health system planning, environmental planning, how are we building our cities, how are we encouraging people to have a healthier lifestyle, food security. So it goes beyond just the patient level. So in summary, providing patients with the medications that we know are proven to work, and also creating an enabling environment that allows them to support healthy lifestyle practices.
Okay, thank you so much. I don't know whether the audience wants to make any commentaries or question.
Hi, it's very nice talk. My name is Fona. I'm from Indonesia, but currently studying global health at Oxford. So as someone coming from Indonesia, it really resonates with me with this talk. My question is, Sandra mentioned about how can we learn from the infectious disease program as chronic disease to implement that in secondary prevention for CVD. But the thing is, as we move beyond donor-driven programs and we want to strengthening the health system, how do we overcome the barriers in low and middle income countries? Because you mentioned multiple times about the access to medication, and it is very costly, especially when we give them the medication up front, but it's very costly in low and middle income countries. So how do we tackle the financial, and what are the lessons learned from global health program in infectious disease in low and middle income countries? Thank you.
Thank you. That's a fantastic question. When I said we can learn from infectious diseases world, especially in low middle income countries, if you think about it, like, for instance, let me with the example of HIV, apart from the medications are one thing, but there was a lot of patient advocacy, there was a lot of patient education, there was a lot of society community mobilization in terms of educating patients on, about their disease and how to take care of themselves. I used to tell my residents that the average HIV patient knows more about their disease than the average CVD patient, right? Even in clinics, there's education sessions with nurses and other healthcare providers before they even see doctors. Like, we can adopt that kind of system in educating our CVD patients. We can have chronic disease models in clinics where we are dealing with multiple other risk factors as well. And in terms of medications, that has to come from the government. Like, we have to have national health insurance that actually provides coverage for cardiovascular medications. Many national health insurance programs in low middle income countries provide very minimal coverage of secondary prevention medication, and that has to change. So until that changes, we're going to keep having problems with access because, as you said, they are very expensive meds. So if they're not covered to some extent by national insurance policies for medications, then we're still going to just keep having the same problems, right? Many of our insurance policies cover HIV medications, cover tuberculosis medications, but they don't cover CVD medications, and that has to change.
Can I pick up one
Yes,
additional
go ahead.
comment on that? I mean, I think that it is good to lean on government, but I worry that if we lean on government only, sometimes that might not, also land this. I think the problem of cost in a lot of low-income countries is that the cost is set at the cost of the international cost. Yet it doesn't need to be at that cost. Originator brands set a cost, and after they're off patent, which all of these secondary prevention medicines are, they shouldn't be at that cost anymore. So I think we need to question the cost that they're being provided at. There are a number of learnings from infectious diseases, actually, with respect to HIV medicines. There are things like, localized productions, countries encouraging local production of manufacture production of these medicines. There are also things about product industry partnerships where industries are, given various credits if they provide at lower costs medicines for certain areas of countries. There are other things with respect to distribution in terms of making that more efficient. And even if you think about all the electronic things that are able, it's about supply-demand mismatch and being able to track all of those sort of things better. So anyway, just a few other sort of things that need to be considered. I think we need to also encourage our industry partners, given that there's a lot of them here, that they can play an important part, I think, in the addressing of this really massive problem. And yes, I think that, governments should be accountable for, but I think industry, which is making a lot of funds of this, could also help.
So thank you so much. I think it's been fantastic 60 minutes where we've been discussing a very serious and common problem that affects all of us, and definitely your points of views, your opinions are extremely important, and I hope that they can help us as World Heart Federation support and really try to reduce the burden of disease and bring this to authorities, medical societies, patient organizations, lay people all over the world, and really see how we can help reduce the burden of disease. Again, I really like to thank you all. I thank the audience, thank Amgen for supporting this. And I do hope that you keep enjoying our World Congress of Cardiology and the ESC Congress. And I hope to see you next year in Rio de Janeiro, where the World Congress of Cardiology will be together with our Brazilian Congress. So thanks so much.